Hi friends and colleagues, welcome to my cardiovascular YouTube channel. I'm Abdul Manfi, interventional cardiologist and structural heart consultant in Houston, Texas. This channel will be dedicated for learning and education, focusing on the latest in the field, from clinical trials to the newest technologies and updates on cardiovascular diagnostic and intervention management, with emphasis on case-based learning. I had the pleasure of using social media for cardiology education and learning since 2014, using multiple platforms like Twitter and Facebook and LinkedIn. I believe YouTube is another strong tool that can help spread the knowledge and convey great messages with ease of learning and accessibility for everyone. So please consider subscribing to my channel if you're interested, and I will be happy to hear your feedback and comments with any ideas that makes this a better experience for all of us. Today I'm gonna speak about important topics, which is MitraClip therapy for secondary mitral regurgitation. What did we learn from the ACC 2023? My today's presentation will be divided into a few segments. So I will talk initially about the classification of mitral regurgitation, and then I will go over the various options for treatment that are available today. And then I will go in little depth about the 5-year follow-up data for MitraClip therapy for secondary MR, which was presented at the last ACC meeting. And I will finally end my presentation with the case presentation and treatment plan and step by step. So as you all know, that severe MR typically has to be classified as either as a primary MR or secondary MR. Primary MR is usually the pathology lies at the level of the valve leaflet. So there is abnormal structure in the valve anatomy, whether it's a prolapse, whether it's a cleft, whether it's a calcification, whether it's a rheumatic heart disease. Anything that can affect the leaflet function lead to malcoaptation and lead to regurgitation. And the primary MR has been historically classified according to Carpentier classification. He's a surgeon that put this classification a long time ago. Type 1, Type 2, and Type 3A and Type 3B. Typically the LV function is normal, and the problem is in the leaflets. Until late in the disease, where if not treated, then also the heart will get congestive heart failure as well. On the contrary, secondary MR is the opposite. The mitral leaflets are usually normal. There is no pathology in the mitral leaflet, but the process rather start at the ventricle or in the atria. Most likely, or most commonly in the ventricle, about 90% of the cases where the ventricle is abnormal, there is a congestive heart failure, there's a low LV ejection fraction. Whether it's ischemic or non-ischemic, there's two main types, and that will in turn lead to defective in the subvalvular apparatus, lead to defective in the papillary muscle, defect in the chordae, tendineae, etc. There is about 10% of functional MR or secondary MR could be atrial, whereas the pathology happen in the left atrium due to significant severe or long-standing atrial fibrillation, leading to enlarged left atrium and then enlarging annulus. And in this subtype, the LV function will be normal. As you know, this distinction is important. Even the guidelines has used this distinction to delineate the therapeutic options for each one of them. For example, primary MR, still surgery is the gold standard with repair for the primary MR, gives the longest durable treatment option. And then MitraClip can be applied, or transcatheter edge-to-edge repair can be applied in very high-risk cases or inoperable patients with severe primary MR. On the opposite side, secondary MR, usually medical therapy is the first line, with guideline-directed medical therapy, which we'll talk about it later. And then if that doesn't help the patient, still symptomatic, then you can also utilize a CRT and ICD as well. And MitraClip can be added as a therapy. I think it's a class 2A currently with the latest guideline, and surgery is a class 2B. This study published by Shem et al. At the Innovations in 2022, which I chose to share with you today, is a very comprehensive review of the mitral regurgitation, case selection and management options. As you can see here, the study starts with first verifying the symptoms and signs of severe MR by clinical examination, and then adjunctive testing including pro-BNP, echocardiography, diagnostic heart catheterization, and then also try to assess the etiology of the MR by looking at the annulus, looking at the leaflet, looking at the LV function, and then determine the severity of the MR with multiple criteria, as we know from guidelines. Also evaluate left and right heart chambers, pulmonary hypertension, and other valve disease. And this will give us a complete idea of where to localize our patients, whether it's a primary MR, secondary MR, what's the risk assessment if it's a primary MR, and then we can basically decide whether to go MitraClip therapy versus surgery according to the classification of the MR and also surgical risk. Next, we have a case presentation here. We have a patient who's 72-year-old male who is known to have severe symptomatic mitral regurgitation, was referred to our structural heart program for further assessment and management. His MR was deemed to be a secondary MR due to ischemic cardiomyopathy. Patient has a prior history of coronary disease with history of CABG about 10 years ago. Obviously has a high STS score of 10.5%. Also history of AICD and other comorbidities including hypertension, hyperlipidemia, and peripheral vascular disease. Workup including left and right heart catheterization showed no need for revascularization, also mild pulmonary hypertension. TE confirmed severity with various criteria. AKG showed right bundle branch block with QRS of complex of 130, normal sinus rhythm, seen by EP and deemed not candidate for CRT. Medical therapy, patient was taking Coreg, Entresto, Lasix, and spironolactone. We will come back to our patient at the end of the presentation. So next I will talk about the 5-year follow-up after transcatheter repair for secondary mitral regurgitation, the COAPT trial, presented by Dr. Greg Stone at the latest ACC meeting in 2023. Dr. Stone, on behalf of the COAPT investigators, has thankfully conducted the trial, and this is a very important landmark trial, and that's changed practice and also changed the guidelines. So we used to have the 2 years data, and now we're getting the 5 years follow-up data. So let's take a deep dive into the study and see what did it show. The study was simultaneously published at the New England Journal of Medicine, and it showed that TEER, or transcatheter edge-to-edge repair for patients with severe secondary mitral regurgitation, was safe, cut the rate of hospitalization for heart failure, and reduced all-cause deaths. As you all know, COAPT trial, COAPT stands for Cardiovascular Outcome Assessment for MitraClip Percutaneous Therapy for heart failure patients with functional mitral regurgitation. It's a parallel control, open label, multi-center trial in 614 patients with heart failure and moderate to severe 3+ or severe 4+ secondary MR who remain symptomatic despite maximally tolerated guideline medical therapy. Randomized 1:1 to MitraClip plus guideline directed medical therapy, about 302 patients, and guideline medical therapy alone, about 312 patients. The key inclusion criteria was moderate to severe 3+ or severe 4+ secondary mitral regurgitation confirmed by echo core lab, LV ejection fraction of 20% to 50%, and LV in systolic dimension less than or equal to 7 centimeter. A New York Heart Association class 2 to 4, despite stable maximally tolerated guideline directed medical therapy and CRT if appropriate. Heart failure hospitalization within 12 months and or elevated pro-BNP with NT-pro-BNP more than 1500. Exclusion criteria were stage D heart failure with hemodynamic instability or shock, coronary artery disease requiring revascularization, COPD requiring continuous home oxygen or chronic steroid use, severe pulmonary hypertension, or moderate to severe RV dysfunction, aortic valve disease or tricuspid valve disease requiring surgery or transcatheter therapy, mitral valve orifice less than 4 square centimeter by echo assessment. The baseline characteristic for both groups, the control arm and the device arm, were comparable. Age was about 71 in both groups. 2/3 were male. Almost 1/3 has diabetes in both arms. Hypertension was equally present in about 80% of patients. Hypercholesterolemia about half. Prior MI about half, same. Prior PCI about similar, 43 to 49%. Prior CABG, prior stroke, TIA, and peripheral vascular disease. Also, BMI was comparable. Kidney function, PNB level, pro-PNB level, STS score, also comparable. Etiology of congestive heart failure, 60% in both groups were ischemic and 40% were non-ischemic. A New York Heart Association class, both groups contain high number of class 2 and class 3 in both groups, an equal percentage. Hospitalization, heart failure hospitalization within 1 year, about 60% in both groups. Prior CRT, about 35 to 40%, both groups. And similar thing with a prior ICD. MR severity, 3 plus and 4 plus, both equal. Effective regurgitation orifice area of 0.4 square centimeter in both groups. Same thing for ejection fraction, about 30% in EF in both groups. And moderate pulmonary hypertension in both groups, mild to moderate pulmonary hypertension in both groups. The study showed the primary effectiveness at 2 years. As you could see here, the follow-up from the day of the trial started till 2 years after the randomization. There's a clear benefit for MitraClip over the MitraClip plus medical therapy over the medical therapy alone. As you can see, the two curves separate almost from day one, and they are divergent, and the separation is increased as we go on. So this is a clear win for transcatheter edge-to-edge repair as an addition therapy for guideline-directed medical therapy in randomized controlled trial. And the primary effective endpoints were all heart failure hospitalization were reduced. So what happened after that? As you can see here, the curve keeps continuing to go in the same trajectory. So at 5 years, same distance as you can see between the control arm on the blue curve and the device arm on the green curve. So the primary effectiveness endpoint was all heart failure hospitalization within 2 years of follow-up. After 5 years, death or heart failure hospitalization occurred in 73% in the TEER group and 91.5% in the control group. The analyzed rate of heart failure hospitalization through 5 years was about 33% per year for TEER and 57% per year for control group. Overall, TEER was associated with 28% risk of reduction in all-cause mortality. This slide shows what we mentioned earlier. As you could see, the number of events in both groups, the device arm and the medical therapy alone arm, both the events are high in both groups, but still the device arm with the MitraClip carry better event rates. I think the reason is why the events are higher on both arms, because the congestive heart failure and severe mitral regurgitation is a bad combination, is a bad disease. No matter what you do, you need more invention and more development of new therapies to improve the prognosis despite all what we have today. The primary safety outcomes through 5 years was also reported, and it showed overall the device has a high safety profile. All safety events at 30 days were about 1.4%, and at 5 years was 10%. Device-specific events like a single leaflet device attachment or SLDA were less than 1% at 30 days, stay the same at 5 years. Device embolization was less than 1% at 30 days and stay the same at 5 years. Endocarditis requiring surgery was 0% from beginning till the end. Mitral stenosis requiring surgery was the same, no events. Any device-related complication requiring non-elective cardiovascular surgery were also very low. As far as the progressive heart failure unrelated to the device complications requiring LVAD or transplantation, for LVAD was 0% at 30 days and was about 6.5% at 5 years. For heart transplantation was 0% at 30 days and 4.7% at 5 years. A 5-year death or heart failure hospitalization subgroup analysis were also performed in detail, and as you can see here in this slide, there are many subgroup analyses were studied according to patient age, sex, etiology of cardiomyopathy, prior CRT, heart failure hospitalization in prior year, baseline in New York Heart class, STS score, surgical risk status, baseline MR grade, baseline LV ejection fraction, baseline LV end diastolic volume. At all these subgroups, the result was the same. Comparing the CLIB arm versus the medical therapy alone arm, all favors the group with the medical therapy and the device. No matter what group analysis you do, it's the same answer. As far as mortality endpoint, so all-cause mortality at 60 months was 67% on the medical therapy alone arm and was found to be 57% on the CLIB arm with the hazard ratio of 0.72. Before 24 months, crossover was not allowed per study protocol, so you could see the mortality difference. All-cause mortality in the medical therapy alone arm was 42% versus the mortality in the device arm, which is the CLIB arm, 28%. So there's a big gap here. After 2 years, crossover was allowed, meaning that some patients from the medical therapy alone arm was allowed to get MitraClip because their condition was deteriorating, and the 60 months or 5 years mortality outcome in the whole study was 40% in the device arm and 42% on the medical therapy alone arm. This slide shows in some detail the crossover treatment in the control arm. Basically, we have 312 patients who were randomized to guideline-directed medical therapy alone. There is a percentage of those patients at 2 years were not eligible for crossover, about 169 patients, because many of them has died. Some got LVAD, some got transplant, withdrawals, and loss of follow-ups, etc. And for those who are eligible for crossover, only 5 patients receive MitraClip therapy before 2 years, about 5 patients, and about 62 receive MitraClip therapy after 2 years. So the total number of patients who received MitraClip therapy or had a crossover is about 67 patients out of the 312, which is about 21.5%. This slide showed 3 curves. Basically, it studies the death or heart failure hospitalization after crossovers. As you can see, the blue curve here that showed the worst outcome is the group for the control group, which is the guideline-directed medical therapy without MitraClip, which is about 312 patients, showed the worst outcome. The curve in green is the MitraClip arm or the device arm, which showed much better prognosis. And there's another curve now here, which is the curve in orange, is showing the part of the medical therapy arm that has crossed over to a CLIB therapy. And this is basically 67 patients who received MitraClip and the therapy as a crossover to see the outcome after that. And you could see here their outcome and their events are close to the MitraClip therapy arm, which is favorable. Conclusions and implications in patients with heart failure and severe secondary mitral regurgitation who remain symptomatic despite optimal medical therapy. Transcatheter edge-to-edge repair with MitraClip was safe. reduce the rate of heart failure hospitalizations, and improve survival during 5 years follow-up. Those outcomes were consistent across all pre-specified subgroups, regardless of patient's age, sex, MR severity, left ventricular function and volume, cardiomyopathy, etiology, and surgical risk. Symptomatic status in New York Heart Association class was also improved throughout the 5 years follow-up, and MitraClip treatment provided durable repair of mitral regurgitation. Treatment effects were reduced after 2 to 3 years, in large part due to MitraClip treatment in 44.9% of control arm patients surviving to 2 years. The prognosis of the control group patients so treated was substantially improved, similar to that of patients originally assigned to MitraClip treatment. However, nearly half of the control group patients have died before becoming eligible for crossover at 2 years. Heart failure patients appropriate for TEER with the MitraClip should therefore be identified and considered for treatment as early as possible. Finally, despite the favorable risk-benefit profile of the MitraClip in this setting, adverse outcomes continued to accrue in both groups, such as 91.5% of the control group patients and 73.6% of the device group patients had either died or been hospitalized for heart failure within 5 years. These findings emphasize the need for further therapies to address the underlying left ventricular dysfunction in this high-risk population. After we completed the reviewing the 5 years follow-up data from the COAPT trial for MitraClip for secondary MR, let's go back to our patients, and I will remind you with the patient presentation here. We have a 72-year-old male who was referred to our structural heart program for further management for his severe symptomatic mitral regurgitation, New York Heart Association class 3 to 4. Patient had history of coronary disease, status post CABG 10 years ago, so ischemic cardiomyopathy, ejection fraction of 20 to 25%, status post AICD. Other history include hypertension, hyperlipidemia, and peripheral arterial disease. Based on his data, STS score was about 10.5%, so it's a high risk. Workup included left heart catheterization, right heart catheterization that showed no need for revascularization with moderate pulmonary hypertension. TE images, I'll show you the images in a later slide, confirmed severity with the effective regurgitant orifice area of 0.45 square centimeter, regurgitant volume of 66 cc, regurgitant fraction of 50%, and pulmonary vein reversal. Anatomy was suitable for good transeptal, and we have enough posterior leaflet length with no evidence of mitral stenosis. AKG showed right bundle branch block with the QRS complex of 130 milliseconds, normal sinus rhythm with no atrial fibrillation. Patient was seen by electrophysiologist and deemed not good candidate for CRT. As you know, there is a 3 major criteria for CRT beside congestive heart failure with ejection fraction less than 35%. Either you have a left bundle branch block with the QRS complex duration more than 120 milliseconds, or you have a non-left bundle branch block with the QRS complex duration of more than 150, or you have RV pacing more than 40%. Those 3 criteria dictate whether the patient is a good candidate for CRT or not. Our patient was in good medical therapy, including beta blockers, Entresto, Lasix, and spironolactone. So here you can see the TE images with multiple views, and as you can tell, there is evidence of severe mitral regurgitation. Also, the anatomy is suitable for MitraClip. We have enough posterior leaflet length, and there is no significant calcification or MAC. Also, there is no evidence of mitral valve stenosis. We also have to exclude any clot in the left atrial appendage with the TE to make sure before we proceed with the MitraClip procedure. Access was obtained in the right femoral vein using ultrasound guidance. This is my routine for any femoral access case, ultrasound guided access. And then we went with Baylis Versa Cross for transeptal. As you can see here, the Baylis is in the superior vena cava, and then exchange for radio frequency pre-curved wire. And as you can see, TE pictures on the bottom left, we tint the septum and also wait for measurements and the 0 chamber view. And at this point here we have 4.7 centimeter height, which is really appropriate. So your transceptor has to be superior and posterior. We also confirm with TE the measurements of the valve area, and we confirm that there is no mitral stenosis. Also check the appendage, make sure there's no clot. These are the pre-requested for proceeding with MitraClip procedure. And after we confirm the height and the position, we use radio frequency ablation. We place our wire across in the left atrium, preferably in the left upper pulmonary vein, and then advance our Baylis sheath and dilator under fluoroscopy and TE guidance. Next, as you see here in the multiple pictures, fluoroscopy on the top and TE on the bottom. After we puncture the septum, we advance our guide catheter with the dilator, and we also check with TE to make sure we have enough guide across the septum before we remove the dilator and the wire. At least you need maybe 2 centimeter inside the left atrium to avoid falling back with your guide across the septum and then need to recross again. So 2 centimeters is enough, especially in those patients. They usually have a very large left atrium due to severe mitral regurgitation. And that will be good for maneuverability of the device to cross and direct toward the mitral valve. After that, we advance the clip delivery system through the guide, and we have to straddle, and then after that we advance the clip with the M mode to find the mitral valve trajectory. After we approach the mitral valve, we have to make sure we are perpendicular to the plane of the valve, because we are trying to clip here at A2, P2. That's the most common site for functional mitral regurgitation. So as you can see here, the clip is perpendicular to the mitral valve plane. We before we cross the valve, we have to open the clip, and also we can do independent grasping to check which one is anterior, which one is posterior. As you know, fourth generation clip now is very advanced, and it gives us the opportunity to do independent grasping if need to be. I always try to grasp both leaflets at the same time, but in some difficult cases you have to do independent grasping. So before we cross, we check the posterior and anterior clips, or grippers. And then we cross the valve. We have to go down below both leaflets and make sure both leaflets fall on the clip arms before we drop the grippers. As you can see here in the view, the grippers being dropped. And after that, we confirm that both leaflets are within the arms, and we would drop the grippers. We close the clip slowly, preferably under color. Next. So in these pictures here, we have grasped the leaflet, anterior and posterior, and you can see the 2 orifices on both sides of the clip. So we have enough grasp here. Then we check the mitral jet, make sure we are bisecting the jet, and we have achieved some form of reduction. Also, we check the pulmonary vein reversal to make sure the reversal have disappeared, as you can see here. The other thing we check is the gradient. As you can see here, our gradient is about 3, which is not too far from the baseline gradient. And also we have achieved significant reduction of the mitral regurgitation jet. After grasping the leaflet and tightening the clip, we routinely do invasive assessment of the left atrial pressure, LA pressure, and we compare the final results with the baseline prior to clipping the mitral valve. We look for a significant reduction. As you can see here in this tracing on the top, This is the pre-clip tracing LA pressure. And as you can see in the bottom here, in the bottom right, there is a significant reduction on the LA pressure, which has made us very happy about the result. There is a good observational data that showed a significant reduction in the LA pressure, more than 50% to baseline at the end of the procedure. Is a good predictor of excellent outcomes with mortality benefits compared to regardless of how much MR reduction you achieve on the color flow. So this is a very important confirmation of the successful clip deployment with the reduction of the LA pressure more than 50%. We also at this point here we decided to release the clip, and as you can see here the clip was released, and we retracted the clip delivery catheter, and then we put it back in the guide and did do more assessment to see if we need another clip or not before we take the clip out. At this case, we were happy with the MR reduction, with the result with one clip, XTW. Patients stay overnight usually because it's an inpatient procedure. Next day we do a 2D echo. Typically I close the groin with a figure of 8 suture. In the morning I remove the figure of 8 suture around the vein, and we do a 2D echo assessment prior to the patient discharge. As you can see here, there is a very significant reduction of the MR and the clip is in the place. There is no evidence of dislodgement and we have also measure the area, measure the gradient next day as well. I typically start the patient on aspirin and Plavix for at least a month. I know there is no hard rules for that, but typically it's a short DAPT duration. I'm sure there is a lot of people who does different DAPT duration. So after this echo, after this case was completed, I want to conclude by summarizing what are the lessons learned from the latest data, as we could see from the ACC and from the 5 years COAPT trial studies. So severe MR with congestive heart failure is a bad combination. It carries a high and very significant morbidity and mortality, as you could see. It needs multidisciplinary team approach with congestive heart failure specialist, electrophysiologist, and structuralist. They all collaborate to formulate a plan and arrange the modality of therapy in order: medical therapy, ICD, CRT, MitraClip, etc. Good medical therapy is the key, but good medical therapy should not delay the referral for transcatheter edge-to-edge MitraClip repair. MitraClip is a safe and effective procedure. It's an effective, minimally invasive option with up to 5 years data and randomized control trials. I'd like to thank you so much for watching, and looking forward to sharing with you more clinical evidence, studies, and case-based learning. Thank you.